This is using the disability adjusted life years. But to put this in perspective, major depression is equivalent in burden to society to that of blindness or paraplegia, and active psychosis and schizophrenia is roughly equal to that of someone who is quadriplegic. So when you think about mental illness, a lot of people think of it as an aside. Oftentimes it's the stepchild of healthcare, and one of the messages that I wanted to leave with you today is that that is not the case. There are three numbers I would like you to remember: 6, 17, 25. And no, that's not David's birthday. Well, maybe it is. I don't. 6 years is the half-life of psychological knowledge. If you knew everything there was to know today about what was clinically effective in mental health care, in 6 years, half of that would be obsolete. 17 years is the science to service gap. It takes 17 years for clinical research that's done in the lab to hit the clinician's desktop, if it hits at all. And 25 years is the average loss in life expectancy if you have a serious mental illness in the United States. If you have a serious mental illness in the U.S., you will die on average 25 years younger than your non-seriously mentally ill counterpart, and it will have nothing to do with your mental illness and has everything to do with your lifestyle. So the integration of primary and behavioral health care is critical for the success and the treatment of the whole person in our estimation. So why electronic health records? Those of you who have worked in hospitals will recognize this. This is a real picture from, I think this is from an intensive care unit. If that doesn't scare you. But this is some of the other problems. This is typical medical record storage area in a primary care doc's office. This is one patient record. This is one patient record, behavioral health care record. This is chart 12 of 12. So when people have serious mental illnesses, they tend to not go away. We tend to work with them for quite a long time because there is no cure for mental illness, for chronic mental illnesses like schizophrenia or bipolar disorder. Many of you know this. Applying computer technology is simply finding the right wrench to pound the correct screw. Are you familiar with the term health information exchanges? Is that a term that's the point of it? If I have an electronic record, I'm a primary care doc. He's a behavioral health care specialist. She's an orthopedist. How do we share data about the same person? And in the United States, a lot of effort is going into developing health information exchanges, which are the watering hole, if you will, of electronic data. So what we have, though, right now, prior to health information exchanges in the States, is something like this, where you have any number of entities that have something to do with touching that patient's care in some way, but they fax to here, they call this person, they send this over here. It's very disjointed, and unfortunately behavioral health care is oftentimes out to the side for a variety of reasons, not the least of which is that our confidentiality standards are higher than primary care. And what we want is this, where we have a singular way of communicating across the whole system for the benefit of the patient that we're commonly treating. We call that interoperability, but the reality is you have to become operable before you can become interoperable, and that's the big challenge for the states these days. Or Stephen Wright said, my mechanic told me I couldn't repair your brakes, so I made your horn louder. Just by way of background, in the United States, there are about 950,000 physicians, of which 562,000 roughly are in primary care offices, private offices. Likewise, in the United States, there are almost 6,000 hospitals. But I think one of the things that is interesting is that look at the number of state and federal hospitals, and almost completely they are private entities, either for-profit or non-profit in the United States. The way that electronic health records are being implemented in the states is for you do it on your own. You're a private practitioner, you're a private hospital, you pay for it and you put it in place, and so not surprisingly cost becomes an important issue. As Mark Twain said, facts are stubborn things, but statistics are more pliable. One study showed that only 4% of primary care physicians have a fully implemented electronic health record. 13% reported having some kind of system in place. The implementation varied somewhat across the region where you were in the United States. Perception was generally positive for those that had them, but the largest barrier was, no surprise, cost, since the primary care practice or the primary care physician is himself or herself responsible for the cost of that. Similarly, with hospital-based systems, only about 1.5% of U.S. hospitals have fully implemented electronic systems. That is, all units of the hospital, including radiology, lab, everything is electronic and integrated. but an additional 7.5% or so have some systems in place. Computerized provider order entry or computerized physician order entry, which is really the kind of the nugget of a hospital-based system, and that is the electronic system that allows a physician to enter an order, and from that a cascade of events will occur, including feedback to the physician about what the results were of the lab test or whatever was prescribed. Only about 17% of the hospitals have that in place. Larger hospitals, not surprisingly, teaching hospitals tended to be more advanced in this area, and again, cost was the primary barrier for this. So as a result, in the United States, I'm sorry, getting ahead of myself here, we see this kind of penetration. This is a different study, but this is American Medical Association news. About 6.3% have fully implemented electronic health records. Compare that to what you saw earlier today in terms of the implementations here in Great Britain. You're far ahead of us in terms of implementation, although I would have to look at those data to say whether they are complete implementations or not. That's a surprise to us, but so is this. We talk about behavioral health care. One of the big things that happened in the United States was this Crossing the Quality Chasm report that came out in 2001, talking about essentially the inefficiencies and poor integration that happens in behavioral or in healthcare generally. Compared to general healthcare in the states, behavioral health care has higher levels of stigma, discrimination, patient decision making is not as supported. Diagnosis is more subjective. There's less developed quality measurement infrastructure. You can measure things a lot better in general medicine than you can in behavioral health care. We've got a lot of separate care delivery arrangements. There's lots of coordination for social services, less involvement in the National Health Information Initiative and the use of information technology generally. A lot more solo practice. The different kinds of providers, mental health practitioners include physicians, psychologists, social workers, clinical nurse practitioners, all of whom can practice independently. And we have a different structured marketplace. In my experience, we use different diagnostic nomenclature. ICD-9, oops, back up here. ICD-9 versus DSM-4. Do you guys use DSM for mental health care? Do you know that? It's a different nomenclature, 5 axes versus 1, 5 digits versus 3. Higher standards of confidentiality, particularly for substance use disorders. And we have different IT vendors. The vendors that play in behavioral and med-surg do not play in behavioral health care. But while we are different, we are still part of the team. Those guys who play real football. I just went by the way. In behavioral health care, we have similar problems with penetration in terms of what gets implemented. We have almost everybody has billing implemented for obvious reasons because that's the way we get paid, and the cost of our billing systems is huge. I mean, I tell you, I've been part of an exchange program with behavioral health care leaders from Australia, New Zealand, England, Scotland, and Ireland, and they're all amazed when we show them our billing office, and it's got 20 employees, and they're managing 50 different insurance contracts, and a patient may have 2 contracts, and then different insurance. We have to do cascading and coordinate it. It's a mess, but that's the way we live. So. The big thing that's happening in the United States now is the American Recovery and Reinvestment Act, and that is a $787 billion initiative for the states. Given the exchange rate, I think that's about 6 quid. I made the mistake of taking a cab from Heathrow. I'd stop and take out a loan at the bank.
They're only there for Americans.
Pardon?
They're only there for Americans.
Oh my, yeah. They said they're only there for Americans. Yeah, thank you for supporting the London economy. Glad to help. This is a huge program. It's one of the most significantly funded programs in the United States these days. Just as an aside, and this is one of the things that I've been spending a lot of time in Washington lobbying, because just as an example of how behavioral health care is a stepchild, we were not included in this legislation and therefore not eligible for the funding that would stimulate the implementation of electronic health records. The goal is a significantly measure improvement. I'm not going to go through these in detail, but it's the God, mother, and apple pie story. We want to do better things for everybody.